So the first topic which is related to the in-stent restenosis, and the debate is on the drug-eluting balloon versus the stent. Now the case is already on the podium, on the floor, and this is the 55-year-old male with past history of PTCA and presented with ISR, and what will be the best strategy for the revascularization. And I have to talk about the paclitaxel drug coated balloon assisted imaging, which is the preferred revascularization. Now we all know that the restenosis, when after the stent proximal and distal 5 mm, more than 50% stenosis is called ISR, and several etiological factors play a role in the ISR that is related to the patient, procedure related, and the lesion itself. If you see the patient related, that diabetes or any chronic comorbid conditions play role. The procedure related is really useful things, because the procedure, like if patient stent is under expansion, long stent, or any geographical mismatch, residual plaque at the stent edge, these are the things which we can really find it out, and we can plan the treatment, and that I am going to show in the imaging. And the lesion related factors like long lesions, stent bifurcation, especially osteal lesion like this, and the long lesion like which is in our patient. So these are the culprit or the etiological factor for the ISR. Now in the PCI we have evolved from the plain balloon to the DAS, and now the fourth revolution, that is the DAB. Basically DAB is the semi-compliant balloon, and where anti-proliferative drug is coated and which is released slowly through the vessel during the balloon inflation with a specific inflation time. And these are the drug usually lipophilic, which usually absorb fast and retain for a longer time. And the excipient or the polymer which hold the drug, as well as it releases drug to the vessel wall. So there are mainly the DAB works in stent restenosis, which we usually encounter almost 3% in a angioplasty in a year time, and the small vessel disease and the bifurcation lesion, mainly in the bifurcation, the osteal lesions, where stenting the the side branch where the osteal lesions are involved, and that time DAB is really wonderful. Now coming to the why paclitaxel is used, because paclitaxel is having high lipophilic property. It rapidly intracellular uptake and retention in the vessel wall for nearly a week time, and it acts by irreversibly binding to the microtubules, inhibiting the cell division and migration, and it leads to the structural intracellular changes which causes long lasting effect. And it acts very fast. The incubation period is almost 3 minutes, and it lasts for 12 to 14 days. So long lasting effect, rapid effect, and last longer time, these are the special property. The concentration of the paclitaxel is almost 3 times, because it takes time, the most of the drug which is dispersed in the blood while delivering to the target lesion, and once the paclitaxel balloon deliver a dose to target in a very short time, that is the higher than the total dose released by the DAS. So the drug which is delivered through the drug coated balloon, which is quite higher than the DAS, and with this immediate drug release, there is no need of polymer, and so there is no further late thrombosis or this ISR. Now the safety profile with the paclitaxel in the Texas 4 trial, that has been shown that 5 years we have the safety data. So paclitaxel is really safe in that has been shown long back. Now coming to the comparison between the DAS and the DAB. DAS for the drug delivery require scaffold, where the DAB require balloon, and the drug is coated over that balloon. For the DAS it requires polymer, and the dose of drug is quite high in the DAB, and it releases fast. But the major advantage with the DAB is that there is no need of implant, there is no foreign body after that, and it may last long time, and you may cut down your DAPT, which is really helpful in the long term. This is again same thing, the drug eluting stent slow release and the fast action the slow release with and persistent effect compared to the drug coated balloon immediate release and short lasting effect. Now coming to the imaging really help in the identifying the cause of the ISR. If you see in the A, where the under expansion of the stent itself a major cause, and this is almost 50% of the cases, the culprit, the main reason is the under expansion of the stent. Now in the coming to the B picture, where the plaque after the stent strut it may play role in the future ISR. And in the C picture, there is thrombus in the lumen, and D in the there is a stent stud is not covered in the both stents are not covered. So there is gap between the stent stud, and E there is a dissection and the stent fracture. So these are the different reasons where ISR can form, but among them the under expansion I would say is the major reason, and according to that we can formulate the treatment plan. In the under expansion, where the DAB is really work very well, and most of the time this is the etiology and it works really well. Coming to the multiple stent, when patient is already stented, that time again the DAB is really work really well. Now coming to the evidence. Now the long-term outcomes following DAB versus the thin stud. My friend Kalpesh, he may argue that he can put a thin stud stent in the ISR, but the data almost in favor of almost same, like composite endpoint, target vessel related, myocardial infarction, cardiac death, and TVR. All four are similar in both the groups in the DAB versus the DAS. So the real life registry revealed similar long-term outcome of the thin DS versus DAB, and there was no significant difference in the secondary endpoint like TVR, MI, cardiac death, and dose. Now, again compare with the different paclitaxel versus sirolimus, almost similar kind of drug coated balloon with different drugs, but both are comparable. Now coming to the DAB versus DAS, if you see the MACE in almost all the clinical trial like DESIRE 3, DARE, and PEPCAD, almost it is similar or comparable. So DAB is non-inferior in most of the clinical trial. If you compare in the PACOT trial, the DAB versus POBA, and in that clearly the drug eluting balloon is far ahead of the plain balloon angioplasty. The treatment of coronary ISR with paclitaxel coated balloon catheter is safe and persistently reduces the repeat revascularization during long-term follow-up. Now, and in the ISR DESIRE trial, that has shown that at 36 months the TLR rate was significantly lower in the PCB group compared with the POBA control group. And in the basket small true trial, this is basically trial with the small artery, but the artery size was around 3 and less. So it's not as small as we are thinking. And the outcome is that efficacy and the safety of DCB are similar irrespective of the vessel size. So however, there is a beneficial effect of DCB over the paclitaxel eluting stent regarding the TVR, non-fatal myocardial infarction, and the MACE. And in the small vessels, again the BELLO trial has shown that among patients with small vessel coronary artery disease, a drug coated balloon met criteria for non-inferiority and sometimes superiority for late lumen loss compared with drug eluting stent alone. And the treatment of small vessel disease with the paclitaxel DAB was associated with less angiographic late loss and similar rate of restenosis and revascularization as paclitaxel. Now coming to the debut trial, in that where the bleeding risk is high and you want to avoid to give long-term DAPT, and the PCI in drug-coated balloon was superior to bare metal stent in patient with high bleeding risk, and the percutaneous treatment of bifurcation lesion with DAB resulted in procedural success rate of 100%. So incorporating all the clinical data, this is the meta-analysis which included almost 10 randomized clinical trial, all the trial which I discussed, and that has shown that in coronary ISR treatment, DCB provides similar safety profile as DAS out of 3 years. And this is the meta-analysis of all the small vessel trial like basket, BELLO, that has shown that the MACE risk is almost comparable with the DAS. And this is the SCAR registry where DCB used in the de novo lesions, and that has shown that treatment with DCB has similar risk of TLR and significantly lower risk of TLT compared with new generation DAS up to 5 years. So the DCB work really well in the ISR small vessel as well as a de novo treatment when the patient is having high bleeding risk and where you don't want to give DAPT for the long time. Now coming to the third, this is the third debate, and this is paclitaxel versus sirolimus. Sirolimus, it is having a nanotechnology, but when coming to the clinical role, and that time the clinical data says that sirolimus and the paclitaxel coated balloon, there is no significant difference in the clinical endpoint after 12 months. So even though the technology is the advanced, but the clinical scenario almost similar. Now coming to the guideline. What guideline says, the drug coated balloon and DES both has been given class 1A indication for the ISR, and the IVUS and the OCT should be incorporated in all kind of ISR treatment. Now the practical point before putting the DCB, because it require a better bed preparation. When you are doing a drug coated balloon, you need to dilate the lesion very well. Almost 1-to-1 kind of preparation is required, because once you start tracking your balloon, it should not waste your time inside the manipulation, because once it enter into your tweak and reach to the target lesion, it should be delivered immediately. Otherwise you are going to waste that drug, and it should not remain more than 3 minutes in the blood stream. So basically once you prepare the bed well, and for that you may require rotablation, lithotripsy, and use your IVUS and OCT to see the better preparation. And if result is acceptable, like no limiting flow, no dissection, residual stenosis less than 30%, and FFR more than 0.8, then the DEB work is done, and you can justify your result. If there is dissection or FFR is less than 0.8, then DES is preferred choice. So the DES, there are long list of role of DEB in these small vessel to ISR, branch vessels, bifurcation lesions, long lesions where you don't want to put stent long. So distally you can do a drug coated balloon, and proximally you can put stent, so you can prevent the future event. Now coming to the last slide, and that is the top 10 points. With the DEB, you can homogeneously deliver the drug to the vessel wall, because the drug is embedded over the balloon, so you can deliver the drug in a better way to the overall wall. Second, it releases drug immediately and in the higher doses, which is required because of it is ISR. And the option of using drug coated balloon catheter alone or in a combination may sometime work, because proximally you can stent and the distally you can do DEB, and that in that way you can minimize the long stent. And imaging, yeah, definitely, because imaging helps you to identify the cause, it identifies the morphology of the lesion, and according to that you can choose your DEB versus DES. And if you are using DEB and your case is appropriate for the DEB, so there is no extra metal left behind the body, you can prevent the further ISR or further event. And the potential for reducing the antiplatelet therapy, that is also important, because sometimes this patient is having on high bleeding risk, like especially in the high bleeding risk patients, you have to cut down your DAPT or antiplatelet therapy, and that time DEB really works well. Lower event rate and better long-term safety, that has been shown in almost all the clinical trial. Almost similar kind of efficacy or non-inferior trial in almost all the cases. In patient with recurrent ISR, when patient already stented, ISR develop and again repeat ISR, and that time DEB is the only choice, or CABG. And the last, IVUS OCT with DEB angioplasty is non-inferior to DES. Thank you so much.
So good morning everyone, and welcome to CardioCon 2023. So as Dr. Mukesh sir has spoke about the role of the DCB in management of ISR. So I just have a few points to argue with Dr. Mukesh Ladda sir. So as we have discussed, this is a 55 years male. He underwent the PCI to RCA, which was performed in 2 years back. So presume that he had a drug-eluting stent, which was 4/38. So it is vessel is not a small size. First of all, it is very big vessels, and there is patient is now presented with NSTEMI. So he is already having acute coronary syndrome, and there is a 99% osteal involvement. So as we all know, the osteal involvement of RCA, so it's difficult to treat even native osteal lesions. Here patients having a native osteal ISR. So let us presume that patients had a neoatherosclerosis. That is one of the mechanism of the instant restenosis. So my best strategy to these patients I will do the osteal stenting, as I will consider as a de novo lesion, and it can be instant restenosis. So I can presume from this case there is a Osteal involvement of with the patient with SES, and the DES was used, and there is no other comorbidity like hypertension and diabetic in this patient. So patient related risk factor for ISR is very less in these patients. And as Dr. Mukesh told, that there is a patient who is having a high bleeding list and there is a DAPT is intolerant or contraindicated, you cannot use the DES. But here patient is not having any bleeding list, or neither he is intolerant or not a contraindication for using the DAPT. As we know that in stent restenosis mechanism, there is two main mechanisms. It's discussed that neointimal proliferation or hyperplasia, in which there is a vascular smooth muscle cells proliferation and migration and activation caused by the vessel injury following the mechanical stretch or internal elastic laminar rupture and medial dissections. And there is another mechanism which was discussed, that was the neoatherosclerosis. It may affect the nascent neointima, that in meaning of new disease. So patients had a DES 2 years back. So we presume that patients already have a endothelialized stent structure. So it probably he must be having a neoatherosclerosis rather than the neointimal proliferations. As Dr. Mukesh has discussed, that the patient's related factors, lesion related factors, and procedure related factors, this should be considered when you are treating the patients with the in-stent restenosis. So for us as an intervention cardiologist, the lesion length, lesion related factor and procedure related factor is most important to treat this kind of patients. This is the ISR classification. Just briefly tell about the type 1. This is focal, type B it's diffuse, type 3 it's proliferative, and type 4 is total occlusion. So depending on the involvement of the lesion length, we can classify into 1, 2, 3, 4. And again, the type 1 can be classified into 4 types depending on the ISR has formed. It's type A, means it's gap type B, which involves the margin, and type C, which is involvement of the only focal body, and type 1D, it is a multifocal. Now I'll discuss about why I should prefer the drug-eluting stent in these patients. First, I have a imaging. So once a patient being having a in-stent restenosis or neoatherosclerosis, IOS imaging allows me to real-time assessment of lumen area, plaque compositions, size and distributions, and finding from a meta-analysis suggests that is better clinical and angiographic result may be obtained under IOS guidance when treating patients with ISR. And not only that, the another imaging OCT, which guided stenting, it also improve the clinical outcome as well. So OCT is used to reveal underlying mechanism in patient with stent failure, including ISR and stent thrombosis. So this imaging is absolutely available each and every cath lab. So we don't think about the second layer, which will be gives the recurrence of in-stent stenosis, because now we have IOS and OCT guided angioplasty with using the DES, which will allow to identify stent under expansion, stent fracture, thrombus, dissection, which can be only treated by putting another drug-eluting stent. So these are the image of the IOS and OCT. It's nicely comparable with the histopathologic slides with the in patients with the in-stent restenosis. So experts and guidelines recommended this is class 2A recommendation of using the intravascular imaging. Now point 2, mechanism of DES. As we all know that not only it contains the drug, it also contains the polymer and metallic structure. So nowadays as Mukesh has said, that thin strut DES is now available to treat the native as well as the patients who is having a drug in-stent restenosis. So DES recognized for their strong anti-proliferative and therefore is very attractive management for the ISR. Network meta-analysis has ranked that DES implantation is most effective treatment for the ISR, and head-to-head trials demonstrated there is a superiority of DES implantation with other therapeutic options like balloon angioplasty, intravascular brachytherapy, and paclitaxel DCBs. In de novo lesions, DEB produce profound inhibition of neointimal proliferation and provides scaffold to the prevent recoiling of vessels. So recoiling is another phenomena which involved in mechanism of ISR that cannot be treated with the DCB. And ACS patients with ISR neoatherosclerosis associated with plaque rupture and thrombus formation, which can be fixed with the DES. Clinical study, this was the restenosis REBIS 3 study, and restenosis intrastent balloon angioplasty, which compared with the drug-eluting stent, and they found that use of second generation DES was superior to first generation DES what we are using nowadays, second generation, and there is a third generation even stent are available to treat this kind of patients. And intravascular imaging for treatment guidance had improved the angiographical as well as the clinical outcome in patients with the ISR. So despite of this benefit, we should accept that when patients have a DES ISR, the recurrence rate still, if you treat with either DCB or DES, the 10 to 20% of patients having a ISR recurrence. So it is very difficult to treat the DES ISR. Now, this is a comparison with the endolimus eluting stent versus balloon angioplasty, and they have shown that everolimus eluting stents, it gives the best angiographic result as well as the clinical outcome. This was studied in SR Desire 2 and stent ISR. Then PCI with DES. So there is another hypothesis that if you treat the heterogeneous DES strategy, means patients who is having a one kind of the drug-eluting stent, and if you use a second type of drug-eluting stent, there may be a beneficial and it will prevent the recurrence. But the result was not that much acceptable, and SR Desire did not show any benefit of the heterogeneous DES strategy for treatment of sirolimus eluting stent in ISR. But in REBIS 3 study, there was found that heterogeneous DES strategy may provide superior outcome in patients with the ISR. Then it came to the REBIS 4 study, in which they only studied the everolimus drug-eluting stent. Now specifically, they studied Science Prime versus DCB, and what they found, the EES provide better primary endpoint consisting in segment MLD at the 6th and 9th month angiographic follow-up. In fact, the patients in EES arm had a significantly larger MLD, and p-value was very much significant, and net lumen gain was much more, and lower percentage of diameter stenosis and binary stenosis rate as compared to the DEB arm. And 1 year clinical follow-up, the main clinical outcome in measure of composite of cardiac death, myocardial infarction, and target vessel revascularization was significantly reduced if patients received the everolimus eluting stent as compared to the DCB. Mainly it will be driven by the less need for the target vessel revascularization, and p-value was very significant in this study. These clinical trials for drug-eluting stent versus drug-coated balloon, as already shown by Dr. Mukesh, they are all having a less incidence of the clinical outcome as well as the angiographical outcome as compared to the DCB. In SR Desire 3, REBIS 4, DARE trial, this Pepcard China ISR trial, and Biolox randomized control trial. So these have shown that the DCB DES, either with the paclitaxel or with sirolimus drugs trial, or sirolimus DES or everolimus DES, there will be a less incidence of the MEST at the end point. This study already has shown by Dr. Mukesh that Dadlow study, in which they pulled analysis from the 10 existing randomized clinical trial comparing the DCB angioplasty with repeat DES implantation for the treatment of coronary ISR. And look at the primary efficacy endpoint in terms of target lesion revascularization at the 3 years. There was a longer period, 3 years. And also they have compared the primary safety endpoint composite of all cause of death, myocardial infarction, and target lesion thrombosis at 3 years. So this was the structure for the comparison with DCB versus DES, and what they have shown that in patients who is having a DES ISR, risk of the primary efficacy endpoint was higher in DCB angioplasty than with the repeat DES implantations. Whereas the risk of the primary safety point was numerically lower in patients who was treated with the DCB. But repeat revascularization with EES compared with DCB can reduce the risk of the mesh. So this was the conclusion study from the Daedalus pooled analysis. Now comes to the guideline. As Dr. Mukesh Ladha has shown that European Society of Cardiologists, they are recommending class 1 indications for the use. Once the patient having ISR, you perform the intravascular imaging, mechanical tissue on IVL. If it is yes, you address the mechanical issue. If it is no mechanical issue, you can do the bed preparations of the ISR lesions. And look at the last, if you treat with the drug-eluting stent, so DES is moderately effective as compared to the DCB in this algorithm and an guideline. Now we should not forget about the osteal lesions is difficult to treat because most of osteal lesions require stenting. So if you do debulking therapy with rotablation, IVL, cutting balloon, scoring balloon, high pressure balloon, this can lead to the catastrophic during the procedure. So at that time your DCB will be not useful to treat this catastrophics. Only drug-eluting stent will be useful in case of patients had a bad dissection, no reflow, acute occlusion of artery, hemodynamic instability. In this kind of patient, only drug-eluting stent can be useful. So using DCB only in osteal lesion cannot be accepted like these patients. And patients is having osteal lesions, so DCB is, as Mukesh says, particularly useful when there is a addition of another stent is undesirable. Suppose patients already having a multiple previous stent layer and presence of any major sidebinds, which is not there in our case. It is a typical osteal lesion without involvement of bifurcations, and the vessel size is very big, so you cannot do only DCB in these patients. This is a stent failure, stent under expansion, stent fracture, underside stent, edge dissection, missed overlap section.
Risk for the recurrence of ISR. But if you look at the newer generation of stent which reduce and overall improve the performance because of improvements in platform like thin strut cobalt chromium and polymer free stent now is available. So this care must be taken to ensure adequate lesion preparation to achieve prior to the implantation of new DES for treatment of ISR, and particular care taken to tackle any under expansion of orifices. So for that we have a IOS and OCD. So my take home message on that, specifically EES is superior to DCB in angiographic endpoints with larger MLD, lower diameter stenosis and less binary restenosis. Revascularization with a DES significantly reduce the TAR, TLR and TVR as compared to DCB, and EES also associated with the lower mesh than the DCB. Use of IOS and OCD overcome the disadvantage of second stent layer in ISR and guide the stent expansion and position. Thank you. So good morning everyone, and thank you Kamal bhai. My talk is on sirolimus eluting balloon in a given scenario. So what we don't like in the cath lab. So as an interventionist, your patient is unstable and you don't like, one is calcium, second is a heavy thrombus burden, and third is this in-stent restenosis that has occurred to what stent you have implanted. So these three things you don't like. So ISR is definitely an Achilles heel for most of the intervention cardiologists. Now this is the data which was published in 2015, and clearly the first generation stents have clearly shown that the higher in-stent restenosis rate. With that we have a second generation stent. We have changed the polymer is biodegradable, but the problem is not solved. At 1 year we will again see an in-stent restenosis rate of around 12%, and that increases by 2% every year. So where is the problem? So if you look at the data and analyze it, what we found is the event is actually with the metal. The drug is already gone, you have metal inside, and the metal is creating problem. We have data up to 5 years. So what we can discuss on that part is that
Unfortunately, we don't have this. So this is an indigenous device. You fire and forget. But for in-stent restenosis, unfortunately, we don't have. You have to keep a close follow-up of your patient, because patient can become symptomatic. You have a very resistant in-stent restenosis patients coming back to you. But the trials and scientific literature, what we have learned up till now is that what is our aim? So our aim is very simple. You have a maximum acute gain and you have a minimal late loss. So if you can achieve that in your in-stent restenosis patient, your job is done. So by treating this kind of lesion, you can't be conventional. That is one important. You can't be casual and you can't be complacent. So what you need is basically this. You need an exotic approach which is extraordinarily elegant, and the soldier is not the soldier. In fact, it is a cardiologist in the cath lab using an imaging device for a precision directed intervention. So this classification, we all know this classification. It is almost a 2 decades old classification for a bare metal in-stent restenosis by Roxana Mehran. Although it is relevant in our case because it is an osteal lesion, but with the imaging and various images all the speaker have shown, we have various mechanisms. So beyond a angiographic stenosis, you have various pathophysiology. You can have a neointimal hyperplasia, you can have a neointimal proliferation, you have a stent fracture, you have a geographical miss with the thrombus and calcification. So lot of things happen. But what we have learned from this study of 5 years is that the in-stent restenosis in a drug-eluting stent is most of the time focal. So that is one important message. And secondly, for a drug-eluting stent in restenosis, the ongoing late loss we have observed is up to 5 years. So after the first year, which is a 10 to 12% in-stent restenosis, there is an incremental 2% in-stent restenosis rate up to 5 years. We may have a long-term data that studies are going on. So these are two important messages for when you are treating your in-stent restenosis. So our patient had a 2 risk factors. There are many risk factors. Non-diabetic, non-hypertensive is good for the patient, but 2 important, a different beast. One is a osteal lesion and second is a in-stent restenosis per se. These are the mechanisms that we have already discussed, and this is the Waxman's classification based on the imaging. And if you see the role of drug-eluting stent, which has been unanimously accepted, is only in a stent fracture case. In rest of the other cases, you have to use your experience, imaging, and then take a decision. So our patient is a young male. So young is very important because he is 55, you have a long fruitful life. You don't land up this kind of patient in trouble by doing a zealous work. So it has an RCA in-stent restenosis, the stent is large. So we are not talking about the small vessel disease, and it is a focal in-stent restenosis. Now coming to the RCA osteal beast. So in-stent restenosis of a RCA osteal lesion is an altogether different beast. Then there are data which are available. So this was a paper in 2021, and what it has shown that the first generation stent of course had a higher in-stent osteal restenosis, Second, if you over expand, then the chances of stent fracture is high, and as the points been clear that osteal stentings are difficult. If you protrude more, again the chance of instant restenosis because of stent fracture is high. But every time what they have seen is, I think it is not moving. Excuse me, it's not moving. Move slide. Next slide. So it's always a focal. So the focal part is very important. So this is a dedicated data for RC osteal lesion, and it is again imaging supported. And what in the imaging they have found a stent fracture where you will definitely use stent is only 23%, and calcific nodules which are seen in 11%. So in 32% cases you will have this problem, but rest of the 70% of cases you will have a patient where you can use either stent or a balloon. And this is a recent publication which is published in Euro Intervention. So this is a predictors of repeat PCI of recurrent DES ISR. So you have implanted a stent that the DES occurred, and you have implanted a second stent. So these are the predictors. So LCX has a higher risk, calcification has higher risk. If the patient is coming earlier at 6 months, it is a higher risk, and it is a diffuse lesion that a higher risk. And even with a score of 0, what you have a 12%. So your score is 0, our patient has a score of 0, that there is a 12% risk. So if you use a second stent, you will have a same 12 to 15% risk. And whatever data up till now we have, and we will dissect the data, the risk of drug coated balloon risk is around 15 to 18%. But what if you have a restenosis again, whether you have used stent or a balloon, the restenosis is always going to be focal, and it has been proven that almost 70% of the cases you do intervention, the patient will come back, you will have a focal instant restenosis. That data we have, that almost 70% will have focal. Now if you have implanted a second stent, that the third stent is not recommended. So it is a clear that if you have implanted a second stent, the third stent is not recommended. If you have implanted a second stent, the instant restenosis rate which is very high, then your options will be balloon or a CABG. So why not balloon first rather than waiting for the instant restenosis to occur in the second stent. Now coming to a stent related issue, and we have all experienced this, that a recoil part you have clearly mentioned. Once the balloon is there, the stent expands, you deflate the balloon. That occurs specifically with the RC osteal lesion, circ osteal lesion, and LAD osteal lesions. And current generation stents, we are talking the newer, they are thin studs. So basically to address this, we don't need a current generation thin stud stents. We need a synergy Megatron. So synergy Megatron is a different beast. We all know that is a higher connector. The length of the these peaks are less, and the number of peaks are high, particularly in the first two parts, and later part of the stent had a 3 connectors. The EES comparison with the paclitaxel balloon, the EES was the conventional EES. We are talking about the osteal lesion, that too in the ISR of RCA. So that data does not stand with our case. So this stent is not available. So ideal stent would be this, but this is not available. Advantages, I think Mukesh Bhai has clearly mentioned. So I'll just keep, so what are the number of advantages. So this is the data. Now the red ones are for the drug eluting in stent restenosis. The initial study of 1 year, that was by a Park and group, and they have shown clearly that the target lesion failure rates, all cause of mortality, MIN is almost equivalent. The result change with the Dedalus study, where they have shown that at 3 years, the paclitaxel balloon had some issues. So it is safe, and it is a slightly less effective compared to a stent therapy. But there is a lot of heterogeneity in the data, and what heterogeneity is that they have compared, first of all, the 10 or 11 trials, they have compared paclitaxel balloon to paclitaxel stent. We are not more using paclitaxel stents. When compared, the paclitaxel balloon was compared with the ES, the result favored a stent. There are no data for the focal lesion in stent restenosis. If you look at the trial again, the most of the balloons, paclitaxel balloon which were used, they were releasing 3 microgram per meter square drug. Now which balloon we have right now? That has a 3 mm balloon, 3 microgram release. We don't have that balloon. If you take a Medtronic balloon which is going to be there, it is releasing 4 microgram. So that data is also not, we are not having. If you talk about the Boston balloon, it is releasing 2 microgram. So even though that data is not with us. So if we talk in terms of data also, we cannot generalize paclitaxial balloon eluting device because all are having a different characteristics. So these are the data. And since subgroup analysis, coming to particularly the ACS part, the balloon was found to be effective. Now, why they have to stress on the safety part? It is a different part. So, but because of this reason, we need to have a balloon. Now, coating is a problem with the paclitaxial balloon, we all know. Retention of the particle leading to late mesh is a problem with the paclitaxial balloon. How you prepare your balloon, that is also important. And this is a ghost of Castanov, which the data is clearly shown that in the intervention, that too in a femoropopliteal at the end of 5 years, there was more death and infarction. A lot of people can raise a question, and that is why paclitaxial people have to come up with the data. Now it is safe, because in the peripheral intervention, they have a lot of data. So why do we need a sirolimus balloon is because of all these factors. So sirolimus, we are quite familiar. It is quite safe. It is anti-inflammatory. The only 2 problems and which was solved. One is a tissue absorption, one is a tissue retention. Now coming to balloons of paclitaxial which are available, agent as I mentioned, it is a balloon with the Boston. It releases 2 microgram. We don't have a data. The sequent please, where most of the trials were done, that is not available to us. Now the same 3 microgram release Dior balloon is failed miserably with the stent. So you have a 3 microgram releasing balloon, one is almost found to be quite equal to with the stent, one is miserably failed. So that is a heterogeneity in the data. And we have a 4th Indian balloon which is sirolimus eluting. Now is a recent recall by a Medtronic, and the date I can read is around in the September 2022. They have recalled their balloon, paclitaxial eluting balloon, because it has a gross compliance issue, because the drug coating which was higher, that is 4 microgram per mm square, that had led to a compliance related issue. Dissection increase and the instant stenting, number of stents in a provisional drug eluting strategy, balloon induced strategy, they have to use more stents. That is why the recall was done, and that is why we need a sirolimus balloon. And this balloon is a unique way of preparation. I think sirolimus is encapsulated in the phospholipid layer, and that is why you deliver a drug, and it has an obvious advantage. So facilitates better radiation, circumferential coating, effective drug transfer, and the better tissue availability. The preparation is different compared to the conventional balloon. They implant it at a lower pressure, they spray it, there are 3 folds, and because of that there is an effective drug delivery. There are data also. So before they initiated a trial, the data was done, and the drug stays in the adventitia for 7 days, and that is, the trial was done by none other than Dr. Renu Virmani, and this is the first study. Now this study, if you compare, it was also with the sequent please balloon. It is not with the Magitex balloon, and that found that it is effective. Both the balloons were of the same company, and they found it is equally effective. This was a single arm study, different balloon with the sirolimus, and they also found that it is quite safe. And if you compare the conventional data of late lumen loss, which is again an important strategy in management of in-stent restenosis, it is almost equivalent. So these are the data up till now we have. So late lumen loss was almost 0.31 compared to all the data with the paclitaxial, which is 0.39. So in that terms, we see the sirolimus balloon has scored. We have also data with exclusively Magitex balloon, and this was a registry, and we all know the real world data are quite more important. Their ACS patients were also selected. Focal restenosis 89%, RC intervention almost around 29%, large vessel were selected, and at 3 years they were reasonable target vessel revascularization or of around 4.7%. So it should be considered a fantastic result. And before venturing into doing a drug balloon, I think preparation part we all discussed, but this is a data with the usage of cutting. So ISR Desire 4, they've clearly shown that if you prepare your bed with a cutting balloon or scoring balloon, the effective delivery of the drug occurs, even watermelon seeding. So your lesion is not repaired, and as both the speaker have clearly shown that if you insert a balloon, somehow you have to remove it out, the drug will go. So that is not a strategy. You have to prepare your balloon bed very well. So cutting balloon or scoring balloons plays an important role. So this is a strategy. Europeans follow this strategy. The focal in-stent restenosis, you do ballooning, you have a good result. I think with the image guided strategy, you just come out. You use stent when you have a dissection and other complication which has happened. And use imaging either IVUS or OCT in your cases. So in summary, we are quite familiar with the sirolimus group of stents. In that way, it gives a lot of confidence. Paclitaxel, there are a lot of confusion, and in 2000 data, which is a 2020 data, which is very recent data, that paclitaxel has created problem in the peripheral vascular disease. So that has not gone. So our confidence is shaky. Our patient has come for the in-stent restenosis in 2 years. Younger patient, you will not do things which can create another confusion. And various data is supported. However, the long-term registry and comparative registry are not available. But in this case, I think I will go with the sirolimus stents, because number of things I have mentioned regarding the paclitaxel balloon as well as the use of stent. Thank you.